None of the producers have any financial interest in the products or procedures shown.
Ocular masquerades. The word masquerade comes from the French word masquerade. Masquerades is often used in medical practice for various clinical scenarios. The term was first used in ophthalmology by Theodore to describe a case of conjunctival carcinoma that manifested as chronic conjunctivitis. Today it is used in reference to tumors misdiagnosed as chronic uveitis. In ocular masquerade syndrome, OMS, cells arise from a non-inflammatory origin, intraocular pigment, blood or neoplastic cells. It presents as visual blur, floaters, pain and redness. There may be mild to severe inflammatory reaction with or without mass lesion. We classify OMS as tumor-related and non-tumor-related. The tumor-related OMS is again divided as primary and secondary. Primary can be from intraocular lymphoma or uveal melanoma, while secondaries occur due to metastatic lesions and systemic lymphoma. In other words, one can say OMS as tumors masquerading as uveitis or uveitis masquerading as tumors. Let us see some of the interesting masquerades seen in our clinical practice. A 70-year-old male patient, on examination, patient was pseudophakic and the anterior chamber reaction was grade 4 with thick 2 mm hypopyon. Fundus view was hazy. On eversion of lid, it was shown as brown mass on the superior scleral region with thinned conjunctiva and sclera. Surrounding prominent sentinel vessels were seen. Hence, UBM was utilized and probable diagnosis of ciliary body melanoma was made. Further MRI evaluation confirmed to be a ciliary body melanoma and the patient went in for oncology workup and enucleation was performed. Lesson learned. Hypopyon after cataract surgery is a nightmare for any surgeon. The case taught how vital is the thorough detailed clinical evaluation of eyes with suspected endophthalmitis. Thereby, by timely evaluation, we were able to prevent vitrectomy, which otherwise could have caused seedling or embolization of these malignant cells. A 65-year-old male patient with recurrent vitreous hemorrhage, his ultrasound B scan showed peripheral mass lesion near aura, while MRI showed no definite clue. Hence, ultrasound-guided FNAB was planned. With sterile precautions, the biopsy was obtained from the pars plana. The biopsy turned positive for melanoma. Lesson learned. From this case we learned that an elderly diabetic patient can have a non-diabetic cause for vitreous hemorrhage which can masquerade as underlying tumor causing recurrent bleed. Ciliary body is a small ring-like structure of uvea which is triangular in cross-section. It contributes about 10% of uveal melanomas. When tumor arises from this tissue, it is often hidden behind the iris and lens and remains in the unseen zone. The rich blood supply of this tissue makes it more prone for bleeding. A timely cytology can help in prompt diagnosis in suspicious cases. The other causes of OMS in adults are the secondaries. These secondaries can arise from the tumors located elsewhere in the body, for example, breast carcinoma in a female or lung mass in a male. In this context, let us see the next case. This 68-year-old female patient, on examination, she had conjunctival chemosis and congestion with proptosis and limitation of extraocular movements. Fundus showed ILM folds. She also gave a recent history of stomachache and fever. Her CT head showed proptosis of left eye with orbital opacification, suggestive of orbital cellulitis. After doing the baseline blood investigations and urine cultures, she was started on IV antibiotics. However, her response was poor. Meanwhile, her gastric symptoms aggravated and she underwent an endoscopy gastric biopsy. Her biopsy report came out as carcinoma stomach. On further oncological workup with positron emission tomography, she showed secondaries orbit. She was started on intravenous chemotherapy and there was significant improvement after chemotherapy. Lesson learned. Here we saw a carcinoma stomach presenting as ocular masquerade after cataract surgery. Hence, one has to remember the secondary metastasis as one of the differentials for OMS in cases with elderly, with acute inflammation of eye or orbit. The common features of the OMS are asymmetrical involvement, old age, history of previous malignancy, absence of typical inflammatory signs, initial response and eventual resistance to corticosteroids. Very rarely, a few non-tumor and non-inflammatory causes can present as OMS. These include retinitis pigmentosa, myopic degeneration, intraocular foreign body, infections and drug reactions. Now coming back to OMS classification. Non-tumor type is another type of OMS where a true uveitis can masquerade like a tumor. Tuberculoma or sarcoid granuloma are common inflammatory conditions which can mimic as tumor. Let us see some of the non-tumor masquerades.
A 45-year-old female patient, on ocular examination there was superior scleral edema and congestion. Her anterior chamber showed minimal reaction and early lens change. Her MRI showed mass lesions superiorly with mild enhancement. Fundus fluorescent angiography showed staining of margin. Basic blood investigations including MAN2 was negative. Fine needle aspiration cytology was performed. The cytology showed no malignant cells. The patient was then treated with oral steroids with immunomodulators and there was reduction noted. She finally required phacoemulsification surgery with IOL under steroid cover. A 50-year-old female came with complaints of reduced vision for 2 weeks. On examination, she had relative afferent pupillary defect in left eye. Her anterior segment showed occasional cells. Fundus examination showed peripapillary elevation with hemorrhages and ILM folds.
Her ultrasound and MRI showed choroidal elevation.
MAN2 and quantiferon TB was positive. She was started on antituberculous treatment with steroid cover.
There was significant improvement clinically. Lesson learned. Both the cases showed us how an inflammatory lesion can simulate a tumor on imaging. Case 1 showed a choroiditis appearing as mass lesion on MRI, while Case 2 showed a tuberculous granuloma appearing as choroidal mass on ultrasound. Nevertheless, timely clinical and laboratory tests can aid in prompt diagnosis. How to evaluate? Following a standard working algorithm in routine practice will help in early diagnosis and management. Liver function, PET scan, oncological workup will be required for identification of the metastasis or the primary source. To conclude, ocular masquerade can occur in any patient, at any place and in any form. At times, you may be the first person whom the patient reports. Lack of response to treatment and atypical signs should always raise the suspicion of the masquerade and thereby diagnose these masquerading conditions.